Good evening, ladies and gentlemen. Today it's 7th March 2025. My name is Jacek Borowek, and you are watching and listening the 107th episode of LiVE broadcast. It's a very big pleasure to welcome all of you, our viewers and listeners. Thank you very much for your engagement, for your interactions on social media, and for sharing the word about today's event. Thanks a lot. Your support helps us bring important discussions to wide audience, and this is very, very important for us. Let us know in the comments where you're watching and you're listening from today. And don't forget to add the hashtag #NTLive. Today, I would like to talk once again about pre-hospital medicine in another interesting context. As we know, every day as emergency medical professionals, we really rely on access to proper equipment, medications, and infrastructure. But what happens? What happens when we don't have these resources, when we are forced to act with minimal supplies in unexpected and extreme conditions? How do you manage to stabilize a patient when all you have is what's in your backpack, or sometimes not even that? How can you provide the best possible care when you are isolated for hours or even days away from organized medical care? And what is your approach to handling different challenging scenarios? Floods, pandemics, armed conflicts, these are situations where standard medical protocols may no longer be enough. In such a moments, knowledge and adaptability become life-saving skills. This is exactly what the Austere Emergency Care course prepares us for. The AEC course is developed to teach medical professionals how to provide care in the harshest conditions. The first editions of AEC course in Poland was introduced by EagleMed system at the beginning of the 2025, and two more editions are coming up soon in March and May. But this evening, we like to take a closer look at this subject with one special guest. He is a former paramedic at Oslo University Hospital and the former director of CCAT, which is Critical Care Air Transport Teams in the Norwegian Armed Forces, a founding member of the NATO Special Operations Combat Medic Program in Germany, and he also holds a diploma in tropical nursing from the London School of Hygiene, Tropical Medicine. He has participated in multiple missions in Bosnia, Iraq, and Afghanistan, both on the ground and as a flight medic too. Now retired from the military, and he continues his mission as a director of CPD course and medical training at the College of Remote and Offshore Medicine Foundation. He also works as a consultant for various medical companies, including Medic2, focusing on improving casualty documentation for future generations of medics. Ladies and gentlemen, brothers and sisters in the rescue community, let's give you a warm welcome to Mr. Ulrik Holmström, who will be sharing both experience and knowledge on Austere Emergency Care today, a subject that may one day prove essential to each of us. Then, welcome you. Hello, Ulrik.
Hello, Jacek. How are you?
I'm good. And what about you today?
I'm very fine, and I would really like to extend my gratefulness to your invitation to be a part of your program. It's a great honor to be asked to do this podcast with you and your colleagues.
Thank you very much, Ulrik. This is very kind of. Thanks. Just a few words to our publicum around. Just guys, please don't forget about the hashtag #NTLive. This is quite important for us. And today we will talk about this special course Austere Emergency Care, the topic of today's in our broadcast is. Yes, but anyway, for the starting, I have a few questions to our guest. Where are you now, Eirik? Where is your place? Maybe are you in Norway or somewhere in the secret place? Can I ask about this?
No, I'm not secret anymore. I am very open, and I can tell you exactly. I'm in Kongsberg, or a small little village outside where I live with my wife at the farm, a small farm. It's called Passebekk, but I don't know if anybody knows where it is. It's about 20 kilometers outside of Kongsberg. So I'm actually going to stay here the weekend, and then I'm going to go down to Poland to meet Robert and Eagle Med System for running the second iteration of the AEC course.
Okay, Robert is calling at the moment. I need to take out this telephone. Sorry, Robert. Take a look to notice to get and alive. Sorry for that. At the moment, it's not so nice. I think so.
No, he's
Robert,
he's very eager.
It is. Yeah. Okay. I have one question, quite a special question. Maybe you know that. I hope so. You remember still. You know this number. You know this 1098. What's this number remind of you?
1098.
Yes.
You got to give me some more clues here, because So is it a year, or is it some? Is it the ambulance number in Oslo?
Yes, that's right. This is your ID number from our pre-hospital clinic from the Oslo University Hospital.
Yeah, if people who is watching is from University in Oslo, driving as paramedics or EMTs there, they will probably see that I'm way too old to be here, because 1098 is one of the first numbers in when Akershus and Oslo was joined together.
Yeah, it was a long time ago when you have started.
Yeah.
Do you remember in what year?
So I started my education as EMT in 1988 or 1987. So I don't think you were born. Maybe your parents were born, but
I'm 82.
So I started. That was before. Very interesting, because that was before there was any official education per se. I think in 1988 I did the first EMT course, 3 months course, that was called NOU 76-2. That was the first official education for that was governmental run, but it was run or decided. It was run by the Norwegian Air Ambulance in Akershus, and I was a participant of the first course that they did with the regulation or recommendation from NOU 76-2. So that was my first, and I started in Oslo. I think I took the vikarkurs, substitute course, or what you should call it, in 1994.
Oh, damn it!
Yeah, it was only Storgata at that time. It was not all around.
How many things has been changed? What do you think? It's a lot. How of part 50%? Everything has been changed. What do you think?
I think I'm very privileged to be a part of this kind of pathway for the EMT community in Norway, and I think also in a lot of other countries they are experiencing the same thing now. Because when I started working in Gevarv, which is in Telemark. It's a small county in Norway, and I was driving a one-man armed ambulance. So I was on call in the middle of the night up to a farm where there was a 70-year-old male with a heart attack, and the only helper I had was his wife that was 80 also, in the middle of the night. And we were not able to monitor patients. We were not able to do anything with the patient, basically. We had oxygen and maybe some fluid, which we can talk about later. But the thing was that the way the Norwegian EMT and paramedic and paramedicine system has developed is it's great, because now it's a profession. In the old days, when I started my first professional job in Hallingdal in Norway, it was like I had a taxi driver who was my driver, and I was the medic in the back. Today, we are equal, and everybody is highly educated, I will say.
Yeah. It's true. It is.
So
I'm here.
it's been an enormous pathway for EMT in Norway, but we still
Uh,
have some to go.
I'm part of this system since 2014, so I know a little bit about this system. Yeah, thank you very much, Robert. Robert is here. Hello, Eric. This is a kind of guest for you.
Hello, Robert. I'll meet you
Yeah,
on Tuesday.
yeah. So, okay, but anyway, you have both civilian or military background from the past. Just can you say something about this? Because it's quite of important to know a little bit more about you, about your history from the past.
Okay, so when I was working as an EMT or a paramedic up in the middle of Norway, Geilo, I was called upon by a friend to go to Bosnia in 1994, actually 1993, and the military didn't recognize paramedics at that time. It was nurses and doctors, and then we were we were medics. And the thing in Bosnia was that we didn't have very much casualties per se. We didn't have a lot of incidents. We had some big ones, of course, but the average was not a daily call for us to do. So that when I went back from Bosnia, I stayed 2 years in Bosnia, and then I started in 2003 when Telemark Battalion, the first professional. Besides the special forces, they are of course professional, but Telemark Battalion was the first with the full-time soldiers up in Rena. And one of the first thing that I looked together with my friend, a colleague who is also a paramedic, who was a paramedic and fagutvikler, Bjørn Eidesen, we was looking at what are the military doing for the medics, because when we were signed to the military, there was 3 years contract, or say you could do that 3 times, so you could stay 9 years, and all the education that you had was not civilian recognized. So we were doing a lot of trauma. Of course, we didn't do peds, we didn't do geriatric and all that stuff, but we were doing a lot of trauma, and we become quite good experts on trauma care. And we were always working around the golden hour principles, because that was the doctrine for the NATO at that time. So after we started up there, Bjørn and me, we developed the first military educational program for our soldiers, our medics, to become civilian accredited. And I think actually during my 2 years up there, we had 7 medics who become EMTs from those 3 first year.
Yeah.
Do you want to know more about me?
Yeah,
I'm more into talking about what
of course.
what you
It's
can do.
on the beginning. We want to know a little bit more about the gas.
Okay.
So that's why I would like to ask about this some main things from your military career.
Yeah. So after Telemark Battalion, I stayed there for 3 years. I did the deployment to Iraq, stayed 7 months in Iraq in the beginning of the operation down there as a APC commander / medic on an APC. Then I went back and I was basically going back to my civilian job. But I got a job as a recruitment officer at the Norwegian medical branch, where I stayed 2 or 3 years as a recruitment officer for medical personnel to Afghanistan, basically. Doctors, surgeons, nurses, and medics that was fulfilling the roles in the missions. When in 2008, we were asked to deploy helicopters to Afghanistan because the evacuation was a little bit too slow and the tempo was picking up down there. And I was tasked to develop the medical system for the helicopters. So I was in charge of recruitment, training, and I also did 7 missions myself as a flight paramedic in Afghanistan. A lot of you, at least a couple of your colleagues in Oslo were with me. Robert from Bærum or Asker, I don't know.
Yeah.
And a couple of other guys. After that, I was tasked to do a review of the critical care air transport team, because Norway had, since the early 80s, I think it was, and deal with some of the nurses and doctors from civilian hospitals that if emergency, they could have a SAS airliner configured as a hospital flight and pick up patient. The first mission they had was the tsunami in Asia, but they didn't have ICU capability. They didn't have an intensive care. So I was put in lead. Of course, I had a lot of good colleagues with me who helped me out to manage to do the first CCAT, Critical Care Air Transport Team course. And we started to do equipment and training and all these things necessary. And that's the flight that's going now. And I think they picked up over 2,000 patients from Ukraine. They're landing in, and pardon my Polish, but they're landing in Rzeszów in Poland.
Rzeszów,
okay. taking Ukrainian casualties and ill people to hospitals around Europe. After that one, I was asked to go to the ISDC, International Special Training Center in Fulldorf, Germany, to be an instructor for what we had an AMFR, Advanced Medical First Responder, and ACSC, Advanced Casualty Sustainment course, which is the start of prolonged field care, which is again the start of AEC course, which we're going to discuss a little bit later.
Of course.
After 1 year there, the big thing that happened was that US SOCOM, the Special Operation Command in the US in Fort Bragg, they started to think about, in 2013, they started to think about the tyranny of distance. What happens in Afghanistan and Iraq? We had air superiority. We could have the patient picked up within half an hour at the surgeon table within an hour because we had helicopters. What about Africa? The tyranny of distance. You can be keeping a patient for a long period of time. And also the Nordic countries, the special forces branches in the US has something called 18 Delta, which is a high-level qualified medic with, I think it's 18 months of education. And then in that, they have something called SOCOM, Special Operation Combat Medic, which is a 6 months course. In Norway, Sweden, Denmark, and Finland, they already had a development of that kind of SOCOM course. So I was then hired as the assistant director for developing the NATO SOCOM for European SOF medics. And we did the first one in 2016. Actually, I had quite a good help from a lot of Polish medics from GRUM and JWK or something. I'm getting old. I forget some of those abbreviations, but yeah. So I had
special operators.
So they were also coming over and helping us out developing this course, and also instructors, very good instructors, helping us out running the pilot course in 2016. During that, I was then, because we had 6 months and not only trauma, we had to put in all the other medical stuff like pediatric, and especially we had to do tropical medicine because Africa is a tropical destination. We hired COROM, College of Remote and Offshore Medicine, because they're specialized in tropical diseases. And they did a one week course for us. And the director, Abric O'Kelly, he's the Dean Emeritus at the college, and we connected. So when I was finished in 2020, I went back to Norway, and he hired me to develop and run the short courses in Malta, where our headquarters is. And that's a part of, so College of Remote and Offshore Medicine runs short courses in Malta, which is a part of a bachelor. We have a remote paramedic education, bachelor degree acknowledged by the European Union. We are trying to get it acknowledged in Norway. It is acknowledged as a paramedic in the UK and other countries in Europe. And we also have a master in critical care and some PhD stuff also down there. Our clinics, for those who are interested, our clinics are done in Africa. We have a cooperation with KCMC, Kilimanjaro Christian Medical Center, which we send our students for 1 or 2 months to do clinical rotations like they do in Norway on hospitals. But I can guarantee you are allowed to do a lot more in Africa than you are under supervision, of course, but you can be asked to do some crazy things down there.
Understood. Okay. You have told us about your title in the military area. Is in this time, in these days is with the war, which is next to our country, our Poland. If you can say something about the medical professionals from the NATO system, what do you think? Is it this level of our skills, practical skills, not just these theoretical things? Is it okay? Is it is good enough? Or what do you think about this?
That's a hard question to ask, because you can find highly professional EMTs, paramedics. Well, they don't have paramedics per se in Ukraine at the moment. They have something called feldsher. I cannot quite describe it, but I don't know if your audience and you know what the feldsher is.
We know this title, feldsher. Yeah, we know this.
So in 2018, I think it was, College of Remote and Offshore Medicine was asked by the Ukrainian Health to develop the paramedic to transition from feldsher to paramedic, but because of the full-scale invasion, that didn't. I think we run one or two courses. The thing is, I was in Ukraine last summer because we, again, Quorum was asked to set up a more advanced course, because there's a lot of people training Ukraine medics in T-TRI-C, March algorithms, like the civilian version is, of course, XABC or CABC. Yeah. But the problem was that most of the people we had on courses was musicians, chefs. They're very lack of medics in Ukraine at the moment. And they, of course, they don't have the golden hour evacuation timeline for getting the casualties out within 30 minutes. They can stay for days in the trenches or in what they call a stab point, stabilization points. So they wanted us to teach not the doctors, but the medics that was working evacuation and also at the stabilization points, a little bit more advanced medicine. So we went down there and set up something we call DCRU, Damage Control Resuscitation for Ukraine, with highly focus on some life-saving skills like chest drain, finger thoracostomy, crikes, escharotomy, fasciotomy, those things, and also big emphasis on blood transfusion. Not body transfusion, because that's not doable, but how to manage blood transfusion and how to recognize signs of a hemodynamic unstable patient. The quality of the training and comparing to NATO standards. So pfc.org or the medical system in JSOM and Joint Trauma System in US has actually translated the entire curriculum for T-TRI-C to Ukrainian. So they are now following, and we also emphasized on the prolonged field care CPGs, clinical practical guidelines. So I think most of the Ukrainian teaching or teaching for Ukrainian medics today is according to the T-TRI-C protocols from NATO, because they are translated into Ukrainian. And that was also what we emphasized on. If you're stuck with something that you don't know, look up your CPGs, because as a young medic, paramedic, I could never find myself calling for help or asking somebody, because I know everything. When I was young, I knew everything. I found out that that's not true. I see, I also work as a paramedic for the doctor car in Follo, county nearby Oslo, which not as the emergency car, the Nibilen or the air ambulance, not with anesthesiologists, but with the normal community doctors. And I found it very interesting that every time they have support an ambulance or we go to an elderly lady, they always consult with somebody in the hospital, for example, or another colleague. And I think that we as paramedics in Oslo or in Poland or wherever, we should also know that if you're stuck or if you're uncertain or if you just want a second opinion, call a friend. Just ask for some, get a second opinion. It can actually be a good thing, because you're stressed and you maybe have forgotten something that they can help you with.
Yeah, the communication is one of the main part of our system, our job, everywhere. I think so. It doesn't matter what kind of languages you have, but if we have a good communication, then we can start to doing something important for us and for our patient, and that's why it's so important. I think so.
Absolutely. And also what I see in Ukraine when we're talking about that is that there's a lot of people doing very good job. They have a lot of support. I'm not going to talk politics now because that's a hornet's nest.
Yeah.
But I think that they are doing extremely good medicine with the few resources they have. And the training is a lot of company. The thing that are lacking a little bit in Ukraine, in my opinion, is that there's so many entities teaching down there, and it should be kind of what we are working with now. We are working with a doctor called John Quinn, who's been in Ukraine since 2016. Tremendous doctor. He's been in the front lines and all over. He's currently working in the UK, but he's American. And he is very eager to get a system where you can get some certification acknowledgement. They managed to do blood transfusion acknowledgement. So if you have the basic course for a T-TRIC combat provider, you can do a 2 or 3 day course in blood transfusion, and you are legally by the government of Ukraine legal to do blood transfusion. So making like we do in Oslo and probably other nations around, you need to have a supervisor who stamps your documentation that, hey, you are allowed to give morphine, you are allowed to give blood, and that's something that we should really start working more on, I think.
Yeah, thank you for this sharing. Thank you very much. I will ask you about the basically things about your organization. The College of Remote and Offshore Medicine Foundation is very important to know it a little bit more. All of us should to know. What we should to know about this institution?
So College of Remote and Offshore Medicine was started 10 years ago, or we have a 10 years anniversary this year. It was started by former operators from US and UK with the same thought process that I had when Björn and me was up in Rena. Why are medics that has a long career in the military not getting recognized for anything in the civilian? So they started to do some training and developing a curriculum, which now has resulted in a bachelor program and a master program. So if you are a medic from UK, for example, and you have a lot of training, you can actually bypass year 1 of a bachelor because previous learning. If you can document that you have clinical experience, you have these courses, we can do a RPP, recognition of prior learning, so they can actually go into the program, and they can then do 1 year, 2 years, and become a full bachelor paramedic, or they can do 1 year and then go straight to a master study in critical care. So the college is a non-for-profit. We run this without any funding or any, let's say, support benefits. Well, we don't aim for making money. We aim for making medicine.
Non-profit institution. Yeah.
Yeah. So what we are doing is we are having different kind of courses setting up. Like we are doing courses in ultrasound, which is one of the specialty, tropical medicine, and we also do the training for the practical training for the bachelor's and master students down in Malta.
What about a little bit? What about the statistics? How many students is graduated or finished it? We have. We're talking about a few hundreds, a few thousands.
So we had actually the first graduation, because the bachelor was recognized, I think it's 4 or 5 years ago. And this is part-time. So the thing that's great with this is, one, it's cheap. Well, it's not cheap, but it's cheaper than a lot of other educations. This is a program that you can do online mostly. So it's a self-study. You have 5 years to do the bachelor program, but you can learn in your own pace. We have a lot of people working oil rigs in the North Sea. We have people working in Africa who cannot participate on a normal schedule. So we graduated the 2 first one this year at our big conference, the Medicine in the Mediterranean, which also is coming up next year in the end of last week in January. I recommend you go there. It's a
Yeah.
lot of collaborations.
Thanks.
So we have now in the pipeline, I think we have 70 bachelor students, and I think we have 30 master students.
Yeah.
I'm not the guy sitting in the admin with the numbers, but I think that's the
Of
numbers I
course.
heard. Yeah.
Yeah. Of course. And I have found one very important information about your job, about your organization, about all these people around you. As hospital medicine is our passion, and we truly love what we do. Is it?
Yeah, so the difference between the bachelor program in Norway for a paramedic and the bachelor program we do is that we are focusing on austere care. We are focusing on limited resources places. We are not setting people into, that's why we're using Africa, for example. We are not putting people into big European, high quality, high tech university hospitals. They get what they have in a rural area. And they also need to know that evac is not coming the first 2 days. But one thing that you guys and your listeners should remember, we have students from the UK, from Asia, from India, from Australia. I had 2 students last week, I think it was, from Australia. So we have people all over, and this really is some of the best feedback we get, because it's a worldwide community where you can learn from all over the world what kind of systems they have, what kind of training they have. But one of the UK students, he said prolonged field care is not just for Africa or for Ukraine. During COVID, they was outside the big hospitals for 6 hours with a patient in their ambulance. Is that prolonged field care? Well, maybe when you are
Yeah.
stuck with a traumatic patient or a very sick person in your ambulance for 6 hours just
Yeah.
outside the ER, that's, in my book, a little bit similar to prolonged field care, because
Mm.
there's a lot of things you need to think about. You need to think about nursing care, which we paramedics probably is not the best of, but we think about hydration, urine output. We need to think about movement, bed source, all this stuff. That's things we need to start thinking about when we start to go over the hour, over 2 hour, and so on and so forth.
Mm. Is it
So yeah,
complicated? Yeah. Is it complicated to take all this thing in a completely new part of the system after 10 years? What do you think?
if it's complicated to
To
take,
take all these situations, scenarios, the possibilities, all these things which is included in students' programs, and reality, of course.
no, so the thing is that since it's online, basically, most of the program is like the program in Oslo, the academic portion of it. So the pharmacology, the pathophysiology, and all these things they study online, and they do exam, they do thesis. But what we're doing in Malta, which is my job, is to make sure that they get the proper training. So, for example, on the ARAMP, Award in Remote Medical Technician, which is the basic course, they learn how to treat patients with traumas, treat patients with fever, in a more not simple way, but in a more way of having limited resources. We don't have all the drugs. We don't get the patient out in the next 6 hours. Then for the master students and the end of the third year of the paramedic students, we have something called I-care, intensive care. And
Mm.
that's a little clinic where you might have some more drugs. You might have, if you're lucky, we always put in ultrasound. We always put in blood gas analysis, EPOC or ISTAT. We talk a little bit about ventilators and respirators, how to use them. We're not using the high end like the new ones coming out, Hamilton and stuff like that. We use the old LTV 1000 and stuff like that. So they need to learn what kind of equipment will I come across when I'm deployed to places with less resources. And we train them on that. They have gone through, we are not doing PowerPoint presentations because they should have learned all of that online. So it's
Mm.
clinical stations. It's like OSCEs.
OSCE stations.
But yeah, but it's we don't do OSCEs on every station. But let's say we bring in live casualties with symptoms of a fever, and she's placed in Tanzania. What is a fever with unknown origin? It's malaria until proven
Of
otherwise.
course.
So how to treat malaria, what kind of drugs, how to prevent it, dengue, sepsis, all these things. We try to put up scenarios where they can start thinking and use their academic background into a practical scenario.
Yeah. We have one special man from United Kingdom. He's actually Polish. His name is Paweł Bednarenko. His own profile on the Facebook is about the health system in the United Kingdom, but he is a paramedic. He works for NHS. Good evening, Paweł. It's good to have you today. And we have a lot of friends today. We have a member of SPZOS Rejonowe Pogotowie Ratunkowe. Good evening. We have Alicia today with us. Greeting from Silesia. Thank you very much. Yes, it is a very interesting subject, especially in our geopolitical situation. Of course, I'm agree with you. A lot of comments, a lot of things. Thank you very much, my dear friends, and it's good to have you today in our place. Greetings to all of you. Please share this link with today's topic with Arik. We want to talk a little bit more about, especially about one special course, which I have started to talk about on the beginning. The first edition of ASC course in Poland was introduced by Eagle Med System at the beginning of 2025. And two more editions are coming up soon in March and May. And today we want to take a closer look at the subject. So that's why I really like to know about this kind of main information about the course. We have some part of things which is quite important to know it about this course. Completely general information, main information about the AEC course. Just to please tell something about this.
Yes. So let me do a quick summary of how this was developed. So in as I mentioned, 2013, there was a lot of good and much more intelligent guys than me. You had like Sean Keenan, Abric O'Kelly, Paul Luce, Dennis Jeremiah, and other people in the US at the SOMA conference, Special Operation Medical Assembly that was in Florida at that moment, that was sitting and thinking about this tyranny of distance. We were talking about deploying to Africa. And they was thinking about what should we do if we have to keep the patient for a longer period of time. There were some courses out there. There were some thoughts about it, but there was not a system on it. So they started in 2014. They started something called Prolonged Field Care Podcast and prolongedfieldcare.org, which is a great website. You'll find a lot of information on that one. Then these guys started this for the special forces. It was special forces basically developed. This is how medicine, in my opinion, often develops. It starts with the special forces in war times, and then it comes to the conventional army, and then the civilian catch up on that kind of medicine, because that's where we can research trauma. In 2014, they also started thinking about doing some courses and implemented it in the 18 Delta and the SOCOM, more prolonged field care. So in 2016, when we did the pilot course in Germany for the NATO Special Forces, we implemented a 2-week prolonged field care kind of training, which focused on how to treat the patient for a longer period of time, and also doing telemedicine and what kind of extra equipment do you need. They started in 2017, a company in the US, Ragged Edge Solutions, started something called Darkwood courses, where they did the first 24, 48 hours casualty care in austere environments, let's call it that. And then in 2020, Sean Keenan, who was the lead for one of the doctors in Fort Bragg, or Fort Liberty, it's called now. He did retire, so he was thinking prolonged field care is not only for the military. He is from Colorado, so he was thinking, what about when you're going out, like for example, I was working in Geilo. We had Hardangervidda, which we can go in the wintertime. We can drive for 40 minutes. Then we have to snowmobile for another 40 minutes. Then we have to pick up the patient, and we have 20 kilometers from Geilo to the nearest hospital, 200. So we can keep a patient for 6 hours. What about those kind of situations? So they started thinking about the AEC, Austere Emergency Care course. In 2020, I think, they started and tested this course also in New Zealand. And in 2021, I was in Soma, and I was asked to come up to Colorado and become an instructor. So on behalf of Quorum. So we went up there, and Avery O'Kelly is now the only course director in Europe, and I'm the only course coordinator in Europe. So that's why we are now, Quorum, are going to Poland, because Robert asked to run AEC courses in Poland. And everything is under the umbrella of AEC, or specialized medical standards. So we need to run 3 courses for Robert and make sure that he does a good job, which I'm sure he wants to do. He has to train his own instructor. So the next course, we're going to have Polish instructors teaching, and we're going to evaluate them and see that they are okay. And then on the 3rd course, they're going to run it by themselves with supervision of me and Abrik, and then they will be able to get a license and run AEC courses. We are also setting up this in Germany and Netherlands. We have set it up in Norway. Sea Rescue School is now licensed to do these courses. So what is AEC? AEC is not rocket science. It's just making algorithm and systems for how to manage and what do you need to know to manage a critical ill patient over a longer period of time. What is important of vitals? What is important of treatment? How can you manage with as little equipment as you have in your backpack to treat this patient that could be ill, severe ill, or have a big trauma? They started thinking about something that is called now, which we are using on every courses, and I also implemented in some other courses. It's on the websites and you can download it. It's something called the 12 core capabilities. So they have put, for example, airway management. That's a capability. So what do you need in your ruck, truck, house, and plane? So what would you carry with you in your rucksack? What would you carry to do airway management? Okay, I probably will have a BVM. I probably will have a crike kit, maybe an eye gel. What would you have in your truck? I might have a small ventilator. What would you have in your house? So it's minimum, better, best for those kinds of things. So we divided into 12 capabilities that minimum, better, best placed in a ruck, truck, house, and plane. So you can start packing your kit. For example, pain treatment. What is the minimum you should have? What is the better? What is the best? So for pain treatment, what is the minimum? In my opinion, ketamine. I love ketamine. Not myself, not personally, of course, but
all of us loves
yeah,
ketamine.
we're not going to go into pain treatment in Oslo, but
Not at
but think about it. You have 2 vials of ketamine. Let's say you have 2 vials of 50 milligram per milliliter, and you have a 5 ml, 10 ml vial, and you're going to keep the patient for 24 hours. How are you going to do that? So we have introduced something called TIVA, which is how to dilute into a drip set, so you can keep it for a longer period of time. So there's a lot of these 12 core capabilities in minimum, better, best, and then we start teaching the students how to utilize the equipment you have. And one of the biggest things that we do in this AEC course is something we call improvised medicine. How can you use the equipment you have to do multiple functions? So in Quorum, we have a lot of vendors that coming with new equipment, and we always ask, okay, this can be used for X, but can it also be used for Y? No. Okay, then we don't want it. We need every equipment should be able to do several things. for the patient, because then it will reduce your load when you're carrying it in your backpack. So that's basically the AEC is basically to improve your skills that you already have to become a better healthcare provider for the patient with a minimal equipment and improve the patient's outcome. And what are the student group? So the course is divided into two. It's the basic and the advanced. The basic course is for, let's say, Red Cross personnel, fire brigade, which don't have medicine as their primary work. But Red Cross, Norsk Folkehjelp, all these civilian organizations who do a lot of good work when it's needed, but they have other jobs, so they don't focus on medicine. Then we have the advanced, which you have to be a minimum paramedic or a nurse or a doctor. Actually, the last course we run in Horten, and this course is also approved by the Norwegian Doctor Union, by the way. It gives doctor credits. So for the first time we had, I think it was 5 or 7 doctors, normal doctors that was just finished with their we also have an anesthesiologist and a surgeon on that course, actually. They were going to deploy to Africa, so that's why they went to this course, and we got pretty good feedback from that one.
Yeah, thank you very much. Michał is with us today. Hello, buddy. Good evening for you, Eirik. Good evening for all of you guys. Yes, we have a lot of comments. Łukasz, yeah, his favorite medicine is paracetamol, so not ketamine.
Well, Łukasz, I love your comment, because what we always teach is, why do you forget paracetamol? Even though you don't have liquid paracetamol, IV paracetamol, we always use paracetamol as the baseline, because that's proven, that's documented, that paracetamol is actually for trauma and for pain is one of the best things that you can give the patient as a baseline, and then you can topping up with other analgesia or painkillers.
It's very important comments. And Michał, his comments is also very nice. Improves the equipment known previously as monkey medicine.
Yeah, I agree. There's a lot of things that has been said that this is improvised medicine and this will work, but everything we teach is on a Medscape. It has been documented, it has been researched that it works. For example, take improvised tourniquets. There are certain demands to make an improvised tourniquet. For example, on the rescue foil, you can make an improvised tourniquet, but you need to know that you have the specific width, you need to know that you have the windlass, you need to know how to place it. So I agree, some of the things that is out there as improvised medicine, I will also call monkey medicine. But if it's documented, researches, and it's put on Medscape, I will say that that's good enough for me.
Yeah, of course, evidence-based medicine can improve something more about monkey medicine. Nice and good question from Agnieszka. The best thing for pain, it's such as a painkiller, is ojajanie. Eirik, you know what's this mean, ojajanie?
Nope.
Oh, stakaż daj. Oh, yo.
Oh, yeah. So when I was a young paramedic up in the north, I had this very experienced old nurse who was also driving with us, and she was using, I think it's ojajanie, because she said the best painkilling, the best medicine for patient can sometimes just be holding the hand and talking to the
like
patient.
that's why ojajanie is it's a best painkiller. It's even better like ketamine.
Yeah, in some situation I can absolutely agree on that one.
Thank you very much, Agnieszka. Michał, yeah, if you look stupid but it's work, it's not stupid. Yeah, excellent.
Good, Michael.
Simple, clever. Thank you very much for your comments, guys. It's very good. And yes, maybe a little bit more about the main part of about this course, or maybe any ideas to say something a little bit more specific about this AEC course.
So what I would like, if you can, the video I sent you, maybe you can run that one.
I can do it. I can do it right now. Okay, right now.
I think Jacek, you should start it at the beginning.
Yeah, what's happened?
I think there you go.
Yes.
Yeah, there we go. So just to say, I already talked to Sean Keenan to make a new one, because it looks like this course is all about carrying patients. It's not.
Yeah, maybe yes, maybe not.
Yeah, it's a lot. There's some carrying also on the final day. We do 8
3
to
days
10 hours
maybe.
scenario. Yeah, but this is what the course is about. It's just learn how to do good medicine based on proven research, academic proven medicine for the medics who is way out of the hospitals and don't get support in the first 12 hours.
Okay, that's why.
Yeah.
Here we go.
So your question was again, sorry.
Yeah, I would like about this main part of the theoretical training, and maybe a little bit more about the practical things.
Yeah. So when we started talking, we talked about what can this give people who goes to the courses. And the thing is that it's like PHTLS, it's like any ITLS courses or stuff like that. This doesn't give you any jobs. You have to be a medical provider, or if you take the basic course, you need to have interest in medicine. But it will improve your skills. It will set it in a better system. And there will give some credits. If you're from the US, it will give CPD, Continuous Development Program. We are trying to get it into the European academic credit programs, but we have it approved by FORM, if you know what that is, Fellowship of Wilderness Medicine. It's approved by 32 credits for a FORM fellowship. So the reason for going to these courses is your interest in medicine, and of course learning and refreshing your skills.
Yeah, and it was one comment from Łukasz about the volunteers, and that's why I would ask one more time: who is this course intended for?
So depending on how many we have from basic, because we run the course for basics and for advanced simultaneously. Yeah. So what we do is, when we have basics and advanced in the same class, when it comes to airway management, we don't teach the basic students crike. That's only for the paramedics. So we separate them in 2 groups, and the firefighters, the Red Cross people, they go in to train more on hand grips, how to use a BVM, what's the benefit of PEEP, what's the benefit of positioning, and how to evaluate your treatment. Accordingly, we introduce them to ECO2, to EMA capnography, and stuff like that. So we divide them when it comes to advanced skills, like chest drain, finger thoracostomy. That's for the advanced people.
Not
But
for
for the
volunteers.
yeah. So we put it to the level which we think that they are able to apply into their normal jobs, which is a difficulty because there's different. Let's say, for example, in the Netherlands, in Italy, in Sweden, they don't have paramedics. That's not a profession. There's also in France, also I think they don't have paramedics. So, and what are the volunteers allowed to do? Paramedics in Germany or EMTs in Germany are not allowed to do as much as they are in Norway. Norway are not allowed to do as much as they do in some places in the UK or in the US. In the US, for example, there's paramedics flying on the HEMS. They don't use doctors on HEMS. They have flight paramedics or flight nurses. So we always try to find out what are the background of the people and try to teach after their skills. But we have a baseline on what is our curriculum and what is our program, so they will get some benefit out of it and set it in a system. And another thing we really find good feedbacks on is that bringing basic and advanced into the same final exercise, 1 day of just being outside with live casualties, role players, the cooperation between people from the Red Cross and professional paramedics and doctors and how they do the teamwork is actually, the feedback is that that was very, very beneficial, because that's what's going to happen in a normal situation in Norway or in Poland. You have a doctor with you, maybe you have a nurse, you have a paramedic, and then you have volunteers. And teaching the volunteers how to work together with the professional, and the professional what they can utilize the volunteers for, is actually one of the great benefits that we have with this course.
Yeah, understood. Joanna, thank you very much for your question. Just to, if you can, just to please wait a little bit, because I would like ask Eirik about one small thing about the how long is this course and what is the format of the training in the person, online, hybrid? Because Joanna, this is quite an important question.
Yeah. So the course, if you enroll to the course, you will 4 weeks before the course get an online portion that you have to go through. It's a e-learning platform. It's I think it's Moodle actually. So they have to go through that course. It's videos that you have to watch, and you have to take a test. Then you come to the course in person, which is 4 days. And we start with the introduction, and everybody present themselves so we can get the background history on everybody. And then we start with we have some discussions, I will call it. We don't have lectures in that, because we have so variable background from people. We have doctors, we have anesthesiologists, and we talk about, for example, airway, we talk about crush, we talk about massive bleedings, the big killers of patients. And then we go out and we do a lot of skill stations, and we do some small team dynamic training, put them into team as they are in austere environment, and have a casualty discussion boards, and also with mannequins. And we focus a lot on nursing care. So we go through a whole class with nursing care, in hands-on nursing care. I don't know if your people have heard about the HITMAN. It's a acronym for doing nursing care, and you have March Pause, which is another acronym. I can put it out, send it out to you, so you can put it out to the people. It'll take too long to give you that lecture now, but nursing care is one of the important things that we focus on. And then the final day, the 4th day, we start at 8 a.m. With live role players. We send them out to an incident scene. They pick up a patient. We don't have teams bigger than 5. That's our ideal, 4 to 6 people on a team, and they have to divide their roles, team leaders, who's the first medic, and so on. They change during the scenario, and they keep on until 3-4 p.m. And then we have feedback, and we discuss the scenarios. And they might I don't want to tell too much about how we do it, because that's but they get one major casualty, but it could suddenly come in a lot of other casualties, and so it's
yeah. Before Joanna's question, one more question, which is dedicated to practical training. A little bit more about this practical thing.
Can you please put up the blood transfusion training and the ultrasound training pictures I sent you?
This number 1, 2, or 3?
I don't know which order I sent it.
Maybe is this one?
So this is the last course we had in Norway. They are now in a bunker without lights, without electricity, without water, without power on the ground, and the patient is hemodynamic unstable, and they have to do live blood transfusion at the scene. That's one of the things, depending on the nation we are providing the course in. This is in Poland, I think.
Yeah.
This is in Norway again. Yeah.
Robert is here, I think so. Yeah.
This is the clinic. One of the stages in the exercise, where they come into a clinic with lights, and they can start doing more nursing care. They can do more like urine catheterization. They can depend, should we put in a chest drain, should we, let's say you have put in an eye gel for this patient and it's now been 3 hours. Eye gel cannot stay longer than 3 hours. You have to make a definitive airway. Should you do an RSI or should you do a crike? That's the discussion topics that we do for that one. Yeah, so these are the practical things on the FTX. But before we put them into the final training, we give them the lectures on the skill stations, so they learn the procedures.
Yeah. Should I take another the last photo?
Yeah, you can. Yeah,
okay, we have this one.
Yeah, that's we just focus on blood, and this is just so we don't infuse blood. We don't do it. Take blood from one person and give it to the other one. We don't do that. Yeah. That's not legal, so we don't do that. But we do something called auto transfusion. Yeah.
Yeah. Okay. So that question from Joanna. Thank you very much, Joanna. It was on second chance. My question is about the main quorum work. How do you evaluate your students if they work general online? How can you check their practical progress? And Sebastian, his comment is, I think Joanna was asking about the bachelor's and master's, not the course. Sebastian, thank you very much. I think so.
Yeah, I think she's asking about the bachelor and master program. So there's for the bachelor program, we have a doctor, Tom Mallinson, who is a GP and former paramedic working in Scotland, in rural Scotland, and he has a team in the faculty which do live talks with the students. They have to submit essays and tasks during the course, and they have to do that's the online portion. So they monitor the people. We are using different LMS, learning module systems, that is monitored by the faculty. And if you are a student, you have to submit, for example, you've gone through the respiratory system, you have to do a test and you have to do an essay describing, for example, you get a patient case and then you have to describe your treatments. It's like a mini exam.
Yeah.
So that's how we quality insurance. And then on the practical courses, they do OSCE test and they do written exams when they are at my courses in Malta. And they have to pass those exams or they have to resit them later on.
Okay. Thank you very much, Joanna. Thank you for your question. Yes, right here we know all of this. Thank you very much. Okay, guys. Any more comments? Any more questions? Just to think a little bit about this, and I will go to another part of our broadcast today. And I hope you are good. This another, yes. Course or structure. I will ask a little bit more about the final exam. Can you say something about not everything, because it's quite a top secret, especially before the March and May. But anyway, maybe it's good to know a little bit more.
So the course, you come into the course, you have to do the written online exam, so he knows approximately where you're at. And that's also our quality insurance that you have done the online portion of the course. Then we don't have any exams in the courses, but we instructors, we have a student to instructor ratio on 4 students per instructor. So there's always an instructor with 4 students, and we evaluate the students on their teamwork, their procedures, and we give them feedback during the course if it's necessary, or during the exercise if it's necessary, or at the end we do a general for the team first, and then we do one general in the big audience when everybody is, because there are some things that if I have a team like I had in Norway, I had a team that I was monitoring, and they were talking about doing pressers, and they would basically kill the patient because they were giving 1 milligram of adrenaline as a presser. And that was a little bit too much. And that was a good thing, because this, not a good thing for the patient, of course, but it's a good thing to bring up with the audience, because that shows that this is a knowledge that maybe not everybody has, how to do pressers. Maybe we should talk about it in the debrief afterwards. So we don't do exams on the practical course, but we do monitoring and evaluation and feedback.
Okay, thanks a lot. What about the accreditation and certificates like this? A few words about this one.
Yeah. So when you do the course, you will get a certification from Specialized Medical Standards, and you will get a patch. So we have 3 different patches. Let me see. I don't have them here, but yeah, somewhere. So there's a blue patch, a light blue one for the person who has done the basic. There's a gray one for the one who has done the advanced, and there's a black one if you're an instructor. So and you get the certification. So what our aim is, because this is a brand new course, this is not something that is all over the world. It's getting momentum in the US. There's 2 or 3 companies doing AEC courses in the US now. There is Norway, and now Poland and New Zealand who's doing the courses. And if this get more momentum and more people see the benefit of these courses, it might come up. This is just from the top of my head, but like PHTLS. When PHTLS was new, I did one of the first one in the early 90s, I think it was, in Oslo. Everybody wanted PHTLS, and they wanted an AMT certificate for the PHTLS, and that gives accreditation. So like in some of the companies in Germany I'm talking to now that do paramedic for windmill farms and offshore, they are looking into get AEC as an accreditation and mandatory to work on oil rigs, for example. So as of now, it doesn't give any accreditation that will give you a job, but this is our aim down the line to try to get AEC approved as the prolonged field care mandatory course for people who's working in austere environments.
Yeah. What about the expiry dates? Should we take some refresh after 3, 4, 5 years? I think so. Maybe like that.
I went to on a conversation with Sean Keenan, Dr. Sean Keenan, who is the owner and inventor of this course, and they haven't settled it, but they think they're going to follow the PHTLS protocol. So it's going to be I think PHTLS is 4 or 5 years. I haven't done PHTLS since I did it in Oslo in the 90s, so I don't know.
Okay. And one important thing is cash is king. What about the costs and funding? This is quite important to know. Is it expensive or not?
Yes.
And what does this mean, expensive?
Yeah, that's a big big question. What is expensive? This course costs from, depending on where you're at, and I don't know what Robert is charging for the courses. In Norway, it was 1,200 euros. In Malta, we charge 1150, but I think we're doing 1,200 also euros, and it seems very, very expensive. but we are trying to have the best equipment, the best teachers. We're flying in people from all over to get the best quality teaching, and we're also using live role players. Everybody gets hands-on. We have ultrasound equipment. And we are not like reusing a lot of equipment. They get the equipment that they are supposed to train on. That's mandatory for us to tell the new entities who want to run AEC, and that's why we are going down to see that before we set up a new training facility, we need to make sure that they are capable of running it according to the specialized medical standard protocols and procedure. It's a lot of logistic, and it's very high. It sounds a little bit stupid to say that it's learning people how to treat patients with minimum equipment, but the back-end equipment, mannequins, live role players, moulage people. We are hiring in, sometimes we hire in amputees in action, and it's not cheap. So
Flight tickets, everything is cost.
Yeah.
Yeah. And is it the final cost of the course, or should we pay a little bit more after training of something like this? Is it, or just a final?
So that includes the online learning portion. It includes the practical course. It includes the certificate from SMS, and it includes the patch. And you also get into AEC community group. And you can also, so let me also talk about how to become an instructor, because that might be interesting. So everybody needs to do one course as a student. Then if, for example, Robert has now picked out 5 or 6 people from his group that we are going to evaluate as instructors. So they're going to be put on the stand, and they have to teach some of the curriculum with our quorum assistants. If we approve them, they will then run the course with us as observers and make sure that everything is in place, and then they can run it by themselves. So basically, if you want to be an instructor, you go to a course as a student, you are selected to be a course potential course instructor, you've been tested, and then you run by yourself, and then you're approved. So it takes 3 courses.
So is it this quite of same rules like is in the European Resuscitation Council?
I'm not so familiar with the European Resuscitation Council, so I cannot answer that question.
Okay, thank you very much. Another comment from Michał. Knowledge always costs some money. We should remember that in investment in our skills and practice. More immersive, more useful. Thank you very much. This is very, very important. And another question, are you helping with providing accommodation?
That's up to the course. So in Poland, it's Robert who take care of all that back-end system for the students. In Norway, we had a deal with the RS, and of course in Malta we have a landlady who has 8 apartments where 3 people can share for 50 euros a night. So we try to mitigate flight cost. We cannot do anything with, but accommodation, depending on, doctors probably want a fancy hotel, and we paramedics, we can bunk together.
Not paramedics.
So
even in all of the Norway.
Yeah, but the course cost is not including accommodation, food, and travel.
Yeah, thank you very much. Another question from Alicia about the any special areas from the pediatrics patients on geriatric. A little bit maybe more specific information about this one.
So in the course, every location has the possibility. There's a very set schedule on what we're going through, but there are 2 or 3 topics that is elective, which the course, the guy who wants to run the course or the entity wants to run the course can elect. I think in Norway we used blood transfusion and ultrasound, and some peds was a part of the course, but it's not specifically peds or geriatric focused on the courses. It's more the critically ill patient. So we don't have time for 4 days to put in a specific training on peds or geriatrics. It's trauma focused. So remember, it's not general illness or things like that. This is a trauma course.
Mm-hmm. Okay, thank you very much, Alicia. Any more questions just to rightly this? I must just remove these comments. Okay, the topic of today's live broadcast is Austere Emergency Care. Are you satisfied after the first one in Poland?
Yeah, extremely.
Well,
I think Eagle Med System has done a tremendous good check. We did an evaluation with Robert, and it's going to be interesting to see if he's followed our recommendation, which I think he has. He's been communicating with me a lot, asking very good questions. And I think that the way he performed it the first time we were at European Security Academy in
yes, it is.
somewhere in Poland. I don't want to go and try to pronounce the Polish names, but next time we're going to do another location, I think. But the first location was perfect, and the equipment was sufficient, and very eager personnel, very good and dedicated students that really wanted to learn, and that was really helpful for us, because when the students are paying that much amount of money, I suggest, or I expect that they are very eager to learn, and they had a lot of good questions. So yes, I think that Eagle Med System will be coming up after these two courses that we're going to hold in Poland, and they're going to run it by themselves. The thing that I talked to Robert about, and I'm going to address it next meeting with Specialized Medical Standard, is translation into Polish. Because I know that there's some thoughts about getting more students and more interest maybe if you have the curriculum in Polish. So, but as of now, it's only in English. And it's not going to be in Polish while I'm down there, because then I don't understand what you're talking about.
But for you, actually, it's much easier to hold these courses in English than in Norwegian, is it?
Yeah. So also in Norway, we did it in English, most of it. So but like when we had the final exercise and you had a team of 5 in Poland, of course they were talking Polish when they were treating patients. So as an instructor, I had to ask them, okay, but I can see what they're thinking, I can see what they're doing, and then I just asked them in English, and they answered. And it's like, I remember when I was doing the first SACON course in Germany, we decided to have the student in German hospitals. And we had to cancel that after the first course, because when a traumatic patient came into the ER in a German hospital, of course, the doctors don't want to focus on talking English. And then the students from Italy, from Netherlands, from France, all over, they lost it. So I think there's a benefit in having the course in your own language.
Okay, what about the language qualifications? Should we have some A1 or 2, B1, B1, B2, or what do you think in the future if you want to, if you're thinking about the just in English?
In my opinion, we are not going to put up a test to see if the students is qualified to do the course in English. That's up to the students to decide. If you want to pay 1,200 euros and go to a course and you don't know English, and you know that the course is in English, I think you should reconsider if this is the course for you. So I think that that's up to the student to decide if they feel proficient enough. And I can say that I had a lot of students, not in Poland specifically, but students in Malta, and also students in Norway who doesn't speak very good English. But they also told me, as long as we understood what the conversation was about, and of course, there's always room to ask questions. Don't be afraid to ask questions if you don't know what the instructor is asking or what we are talking about.
Yeah, anyway, Marcin, his comment is like, great, translation of AEC is a brilliant idea. still we must remember that the language of austere remote medicine is mostly English. Thank you very much for your comment.
And that's also the thing that we, back to SOCOM in Germany, is that the big buzzword for all of us now, civilian and military, due to the situation we have in Europe, is that we are multinational. We have medics going from Norway, from Poland into Ukraine. We had students from all over the world in Malta, and we need to find a common language and teach the understandable so people can work together, even though you are not from the same country. So I think that knowing English and doing courses in English is good, but it also should be a possibility, in my opinion, to have it in Polish, for example, or Spanish, or
or Norwegian.
Or I think most of the Norwegian understand English.
We can try.
Most of the Polish understand English. All of the Polish I met understand.
But another comment from the Marcin, he need materials in Polish, but it can be a little bit tricky because the next date of the course is next week, I think so. It's it is. It is next week.
Yeah, so we're starting on Thursday next week, and I don't think we have to approval from SMS, from Specialized Medical Standard. I don't think the 2 next courses is going to be in Polish. They're going to be in English because I'm going to be down there, and so. But hopefully, when Robert has got his license, I will work harder on specialized medicine and see if they can think about it and maybe start focusing on it. Then of course we will then address EMS and Robert and the guys to see who can translate it, because we need to have a translator, and we then need to have it back and get it verified that it's the correct and the same educational material, that we are teaching the same thing in a different language.
Yeah, thank you very much, Marcin. Thank you, buddy. Michael, all mnemonic are in English. It will be painful to translate in our native language. Yeah, I'm agree with you. Thank you very much, Michał. Okay, folks, it's 1.5 hours almost. What we should show? Any more shots from
if
this?
You take number 2, and I can just go quickly to it and see if there's some special comments that I was, or some
number
comments.
2. Here we go.
Yeah, so basically what we're trying to do is putting people on the exercise in shitty places. So be ready for physical work, be ready for working with no lights, no water, no food for a long period of time. Next picture.
Here we go.
It's the same, just take the next one. And they've got some light in there. Take the next one.
Yeah, this is what.
Did I send you number 3? Because I would really like to show you the ultrasound picture. Yeah, that's Robert doing. So this is something that's very important. That's 2 things that we very much focus on, based on our experience from our CCAT teams and also my talks with Ukrainian medics when I was down there, is that we have a problem with tourniquets. And tourniquets is put in place correctly. No worries about that. They're following the TTRIC and the march and high and tight in the trenches. I understand that. But the downgrading or converting of a tourniquet is not happening. I think it was approximately 60% of the tourniquet used should have been converted or downgraded. So I had not me, but I have a conversation with a evac personnel who has picked up a patient who has been in the trenches for 3 days with a tourniquet high and tight, with a bullet wound or a fragment in the leg. And of course, that's a total amputation because the tourniquet has been on for 3 days. So this is also what Robert is doing here is suturing. We also do a little suture class if they want to. We also do wound debridement before closing, for example. So this is one of the skills that we also teach in the course.
Okay, the next one.
That's the ultrasound. We bring ultrasound probes with us. We use Butterfly IQ. And if that's one of the things they want to learn, we put in a lecture of not diagnostic ultrasound, but fast find free fluid, and we also do ultrasound for TBI, traumatic brain injury. We can actually ultrasound the eye and find out if there's an increasing in the head, increased pressure in the head. And also we can use ultrasound to see if the hydration status is good by doing the IVC, intravenous cava, measurements of that one. So ultrasound is, in my opinion, I'm very, very focused on ultrasound. I'm trying to put up a couple of ultrasound courses in Norway, waiting for doctor union approval. 2-day course, which is focusing on using ultrasound pre-hospital. I know that in Follo, where I work, we have ultrasound in the doctor car. I know that the anesthesiologist has it. I think we should have it, maybe not in Oslo Centrum, but in the rural areas up at Gardermoen and other places. It might be a helpful tool.
In our country, in our place, in Poland, almost all of ambulances, they have get it, some kind of machines. I'm not sure on the all, but anyway, I know a lot of that. Okay, so we can take another shot.
This is a live casualty that is moulaged, and we emphasize on doing proper moulage, not just marking with Coban and some red stuff on it. We try to make real life injuries, and this is wound packing, where you have to decide, for example, is this something I can suture? Can I debris it? How can I pack it? We teach him wet to dry dressings and how to manage it, because in Oslo I would just put a bandage on it and bring it to Ullevål or to the ER. If you're going to keep this patient for 12-24 hours, you need to think about other things, like I need to clean that wound, I might have to debris the wound, I need to maybe suture the wound.
Excellent. I think so. It was this the last shot, last thought.
Perfect.
Yeah, thank you. Okay. Usually we have some few questions, quite a similar questions between all of episodes. I will ask you about that. I have forgotten about this actually. I will ask you about any books, any literature about some medical things which can be quite good to know it. Any recommendation about the medical books, maybe from your side?
Yeah. So SMS is working on a handbook for this course, specific on the topics that we're teaching. There's a lot of literature out there. One I will strongly recommend it, and I think that Robert can agree that in Poland we brought the Corum Field Guide, which is now 300 pages, coming a new one, updated version in December this year, but it can be bought on Amazon. And that covers all from tropical diseases, cardiac arrest, all the normal drugs. So if you go to Amazon and you put in Corum Field Guide, it's a small pocketbook where you have most of everything we teach. And it's also online, so you can have a subscription for 1 year for the online version, which is also you can use offline, and it had burn calculation, it had drug calculation, it has a lot of other that was something in Polish.
Yeah, it's great recommendation from the Robert.
Okay.
So Corum Guide I will try to find on the Amazon. Thank you very much, Robert. Thank you very much, Eirik. It's because usually I will ask our guests about some books, medical books, or what can be good to know it. Another comment from the Marcin. Do you recommend bringing in a specific equipment? I mean, your personal equipment like chest, west chest, REG, or clothing with you to the ACE course.
Yeah. So one thing first, this is not a tactical course. It's not shooting and stuff like that. So it's not cuff and it's not T-tri-C course. It's focusing on the medicine. So bringing bulletproof vest and helmets and chest rigs. I saw a lot of students bringing their own kit because, my opinion, train as you fight. If you have a specific set that you use in your ambulance services, if you are in the military and you have a specific set like your IFAC or any equipment that you normally use, I would bring it and I will use that one. Med bags, you will get the opportunity on the course to go together as a team, because if you bring your med bag, then maybe the 3 other on the team doesn't know or want to pack it other way. So you have to communicate and agree, where do I put the airway stuff, where do I put the bleeding stuff. So Robert or the EMS will support you with all the medical equipment. But if you have personal equipment that you need to pack in, then I will agree. And also bring clothes that tolerates to be roughly handled. You will be crawling, you will be walking, you will be sweating.
Yeah, all can be damaged. Thanks. Okay, guys. Any more questions? Any more comments? Yes, please. Don't be afraid. Not today. Eirik Hamström on NT Live. Okay. The last words after this episode of NT Live broadcast. Some kind of summary.
I will say that my final word, which I also say at the end of every course, is even though you've done a course, you're not fully educated. You will always have the possibility to learn more. Stay sharp and always look for new courses, new knowledge, and at the final stage, never be afraid to talk to anybody. If you are, I'm wondering, how do I set the ventilator settings? And you don't know, don't say yes, I know. Just ask people, because everybody wants to help others to learn more. Stay sharp.
Yeah, of course. And the last comment from Bartosz Wróbel. He's a flight medic from Polish Air Ambulance. One of the best paramedics from Poland, I think so. I know that. I'm sure of that. Best regards to Eirik, and it was a honor to meet him at the AAC course. You know Bartosz? You remember him?
Yes, I do.
I did. I did.
Nice to hear that you like the course. Thank you.
Thank you very much, Bartek. Okay, Eirik, all of you guys, thank you very much for today. It was very good fun to make this in English. This is my first time in English. Maybe we can try in Norwegian. What do you think, Eirik?
Ja, vi kan gjerne ta hele saken på norsk.
Ja, vi kan bare begynne på norsk og diskutere litt om dette kurset. Hva syns du om det?
Om selve kurset?
Hvis du skal bare invitere norske folk til dette kurset, hvordan det skal bare gjøres, hvordan det skal presenteres?
Nei, altså det jeg anbefaler, det er også å høre på andre nordmenn som har gått på dette kurset, hva de syns om kurset, for det beste er jo å snakke med studentene som har gått gjennom kurset. Jeg syns vi har fått rimelig bra tilbakemeldinger på kurset, spesielt på det siste. Det er faktisk godkjent av Legeforeningen nå, gjennom de som han doktor Stig, nå står det stille med etternavnet, men det er han som er doktoren på RS. Og vi planlegger å kjøre flere kurs i Norge, så hvis det er noen som har noen spesielle spørsmål, så ta gjerne og ta kontakt med meg direkte, og så har du noen spesielle svar. Så jeg kan anbefale det på det sterkeste.
Ja,
ikke fordi at jeg tjener penger på det, ikke fordi at jeg har ingen eierinteresser i det. Jeg er bare en instruktør som blir leid inn. Så, men jeg synes det er et veldig bra kurs, og jeg ser absolutt behovet. Jeg ser også behovet i Norge, spesielt i Finnmark og Geilo, Hardangervidda og de plassene der. Men også i OUS med da en del avstander innimellom der også. Og så vet vi ikke hva som skjer fremover i tiden, hva som vi kommer ut for.
And just to look at these comments, why the Swikong is now playing in the reverse? Just to explain to Michael.
Sorry, we were just having a little quick Norwegian conversation. Sorry, Michael.
Very funny. And Bartosz, his comments is almost like the Vikings without the translate on the Netflix.
So I'm just going to have one last comment for you guys, because this is also one of my tasks in the world. Many people refer to Vikings, to me as a Viking. And when I see people going around on sports events with Viking helmets with horns, I get angry, because Vikings didn't have antlers or horns. They only have a skin. So please don't use those Viking helmets.
You can get a lot of troubles from Norwegian people, for sure.
Yes. Well, Norwegian are the worst one, so they don't know
Yeah,
that
yeah, yeah.
stuff.
Okay.
Okay.
Yes, Eirik, thank you very
Okay.
much.
Thank you for having me, and thank you all to your old listeners. And it was exciting, and I'm looking forward to be in Poland and drink some Zubrowska or what?
Żubrówka.
Zubrowka.
Żubrówka. Have you tasted żubrówka or not?
Well, Robert was kind enough to give me a bottle.
And another type of good drinks? Just żubrówka or something more?
Yeah, of course, I bring a bottle of aquavit.
Akevit. Yes,
Yes.
guys. Yes, Eirik, maybe the last words. You can explain what akevit it's mean. What's this?
Life, water of life. It's a very special Norwegian thing that we drink during Christmas and fatty dinners and get very drunk.
Yeah. So next time, if you want to travel to the Norway, so you need to buy one bottle of akevit, but not Danish, even Swedish, just a Norwegian.
No. Linje aquavit.
Tusen hjertelig takk. Thank you very much, Eirik. Dziękuję bardzo.
Bye bye.
Bye bye. Yes, dobranoc, dziękuję bardzo, drodzy Państwo, to była wielka przyjemność dzisiaj porozmawiać troszkę w innym języku, trochę w innej formie, ale cieszę się, że dotrzymaliście mi dzisiaj czasu. Wszystkiego dobrego. Machamy do Państwa dobrej nocy i do zobaczenia już nie wiadomo gdzie w przyszłym tygodniu. Może w Lubniewicach, tego nikt nie wie. Dobranoc.